Okay, good evening, everybody. Already had one request for the music to be halted because it was, quote, awful. So I apologize for that. It was actually recorded by Toby, Fiona, and myself after a particularly heavy Indian meal. I apologize that people didn't like it. Welcome, everybody. We are very glad today to be speaking to you, albeit remotely, to introduce to you the Maudsley Practice Guidelines for physical health conditions in psychiatry. This is the brainchild of Toby Pillinger, who's been assisted by Fiona Gochran and myself in writing this book, which is an entirely new venture, and we think a very important one. It's available for sale. It's actually in print at the moment, but not quite available. It should be available in a couple of weeks. And you can get 20% off with the promo code VBT12. So my job is to introduce Toby and Fiona and give you an introduction to the book itself, to tell you why we think it's necessary, to give you a quick overview of how the book is used, and then Toby and Fiona will give you an in-depth view of a description of some key topics. And at the end, I hope we have time for some questions that we can answer. If you have problems with the music or any technical aspects, please use the chat function. If you want to ask a non-technical question of the authors, use the Q&A function. And we'll be keeping an eye on that Q&A function throughout the talks. And Toby will curate the questions so that we can have them put together so that we don't have the same question asked over and over again in different ways. So Graham Thornycroft in 2011 wrote about the scandal of premature mortality in people with mental illness. And Graham features actually in my personal reason for believing this book to be important, because when I first started at the Maudsley, for reasons that are now lost to me, Graham gave me a lift to one of the community units in his Golf, which had just been relieved of its radio, which kind of tells you how long ago it was. And at that time, I'd just come from working as a general medical pharmacist in Lewisham Hospital, and I had a passing interest in wound care and happened to mention this. And before I knew it, I was the go-to wound care expert at the Maudsley and at the Bethlehem. And this was very surprising to me, because that certainly wasn't who I was at the previous hospital. But it was clear that most people, if not everybody, who knew anything about wound care at that point had lost their knowledge, or the field had overtaken them, so to speak, such that I, even though I only had a passing interest, became the expert. And it wasn't long, of course, before I became de-skilled and realized what a hopeless venture it was, and was no longer the expert. But I think Toby's had a very similar experience, having spent some time working in general medicine and coming into psychiatry quite late in his career. He, I'm sure, has noticed that there's a severe deficit in general medical clinical skills in people working in all specialist areas, but in psychiatry especially. And it's particularly important in psychiatry because we have this huge disparity in mortality between people with serious mental illness and the general population. And there are lots of proposed reasons for this. One is that the illness itself, schizophrenia, bipolar, may be in some way associated with earlier mortality in a way that we're not quite clear about yet. It may be that people receive less good medical care in psychiatric settings. I say may, in all likelihood that is true. People with severe mental illness are less likely to get help. They're less likely to have peer groups. They're less likely to be married, so they're less likely to be directly looked after. They're less likely to seek help. The medication that we give them very rarely improves their physical condition and very often makes their physical condition worse. And of course, people with serious mental illness live a lifestyle which isn't conducive to a long life, in that they have poor diet and they exercise very little. So the Lancet Psychiatry published its commission report that Toby and Fiona were involved in 2019, and came to various conclusions and indicated that there were particular areas of practice that needed to change or improve, and they were these: to implement a physical health culture for mental health services, to integrate physical and mental health care, one of the key aims of King's Health Partners, to improve the use of medical investigations and treatments, to improve referral pathways. At the Maudsley, we've always had the luxury, so to speak, of King's College Hospital being literally across the road. But that isn't the case with other hospitals, even within our own trust. And we know how difficult it can be to get a referral or even to know to whom to refer. Some of the other aspects emphasized were the provision of lifestyle intervention to improve mortality, and attempt to reduce long-term adverse effects of psychotropic medication, and to avoid diagnostic overshadowing, which is a somewhat abstruse phrase, but if you imagine a patient who complains that he has a transmitter in his head and the television is talking to him and people are out to get him and he's got a pain in his calf, in psychiatry, we would tend to concentrate on the first three to the detriment of the fourth, which might, of course, be highly significant to their physical health. And you'll know, of course, that the NHS frequently comes up with plans, which they don't always call plans. They sometimes call something else. So there is the NHS 5-year forward view, which set out to provide 280,000 health checks in 2018-19 for people with severe mental health problems. So one of the aspects that we're particularly interested in and is covered in some detail in the book is trying to balance the risks and benefits of treatments in psychiatry, particularly treatments in serious mental illness such as schizophrenia. And we're going to use here very briefly antipsychotics as an example, the good, the bad, and the ugly, although I've got a feeling that picture is from the outlaw Josie Wales, but I could be wrong. So the good is that although their reputation is the opposite, drugs used in psychiatry tend to be at least as good as those used in medicine, if not better. So this is a meta-analysis by Stefan Leucht from 2012. The blue blobs are the psychiatric treatment. The one ring there is antipsychotics. The highest blue blob is methylphenidate, which has got the highest effect size in psychiatry. You'll notice that some of the medical treatments have SMDs or effect sizes of 0, which means they don't work at all, or negative, which means that they make things worse. So psychiatry has drugs that work. Continuing with the good, we have drugs that work which seem to, despite their side effects, improve mortality. So this largely Finnish study of a Swedish database showed that patients treated with antipsychotics tended to live longer than those not treated, which is kind of counterintuitive, particularly as we know that schizophrenia itself and antipsychotic drugs are associated with a much greater risk of cardiovascular disease and a much greater risk of outcomes of cardiovascular disease like MI and stroke. So if we take ischemic heart disease as an example, this is the Finnish group again, Crum et al. On the left, you see a dotted line and a solid line. This is women on the right, dotted line and solid line, which is men. The dotted line is the hazard ratio for diagnosis. And you can see that both women and men, left to right, they're no more likely than people in the normal population, so to speak, to be diagnosed with ischemic heart disease. But the solid lines are the death rates from ischemic heart disease. And you can see the massive relative hazard or risk of death from ischemic heart disease in people with schizophrenia. So there's this huge mortality gap of about 15 to 20 years. I showed you in the first graph in the good that antipsychotic use seems to improve mortality, so you get a gain, but they do increase cardiometabolic risk, so you get a loss, and ultimately you get a small net gain. But what few studies there have been done over the past 10 or 20 years seem to show that the net gain is quite small and that the mortality gap is hardly reducing at all. So we already have a Maudsley Prescribing Guidelines. In fact, we already have two because there's another for advanced prescribing psychosis. The Maudsley Prescribing Guidelines in Psychiatry is aimed at specialists working in specialist mental health fields, and it has information on the treatment of mental health problems or mental illnesses, mental health conditions. The Maudsley Guidelines for physical health have an entirely different set of objectives. They are aimed at enhancing the skills of psychiatric practitioners by providing them with a practical toolkit to assess, investigate, and initiate treatments for physical health problems. They also aim to enhance co-working relationships with GPs and other specialities, to enhance the quality of clinical care delivered to patients by the two methods above, and to enhance the patient-practitioner relationship. And this perhaps is the most important aspect, as patients experience that both mental and physical health, their mental and physical health, are being considered together as part of their care. So we need lots of different people to cover all of these aims. And here are pictures of some of them. You will no doubt recognize some of these people who have got: John Moxham, Sean Cross, Louise Howard, Toby and Fiona and myself, and Connolly. Lots and lots of people have given up their time to lend us their expertise in order to come together to give you this very comprehensive guide to the identification, treatment and referral of different physical conditions in a mental health setting. And you can see that there are 89 chapters. They're organized into sections, and we'll be looking at these now with Toby and Fiona. Generally speaking, we have the definition of the complaint, common causes of the complaint of people with SMI, diagnostic principles, when to refer, management, both non-pharmacological and pharmacological. So each of the individual 89 chapters has this structure. So keep your questions coming in as we go. I'm going to hand over to my co-authors now. Fiona, after Toby, will talk about some of the key physical effects of clozapine and their treatment. And Toby now is going to lead you through an in-depth look at some of the key chapters in the Maudsley Practice Guidelines for Physical Health Conditions in Psychiatry. Over to you, Toby.
Thanks a lot. So, as David mentioned, the book is divided into 15 sections, which is essentially based on organ systems or medical subspecialties, as shown here by these individual rectangles. And then these sections are then further divided into chapters based on a particular presenting complaint or a condition. And as David said, we have 89 chapters in total, covering well over 100 different presentations. I think it's probably about 120. So if we take cardiology, endocrinology, respiratory medicine, and then some medical and surgical emergencies as an example, what you can see here is the different chapters that make up those 4 sections. And to give you a flavour of what to expect in those chapters, I'm going to take you through a couple of them in a bit more detail. And bearing in mind the burden of metabolic syndrome in people with serious mental illness, we're going to be focusing on obesity and diabetes in particular. So here is the obesity chapter in its entirety. And the first thing I think you'll probably notice is that we've tried where possible to keep things as succinct and as simple as possible, with, where appropriate, use of figures, tables, information boxes. So these chapters are designed for the jobbing psychiatrist for use in clinical practice, seeing patients and being able to use it rapidly and effectively. As with a number of the chapters in the book, this obesity chapter had both local and international representation. So we had Yuya Mizuno, a postdoctoral fellow at King's, but also a Japanese consultant psychiatrist who led on the chapter, but also with support from Dan Siskind, a professor at the University of Queensland in Australia, who's a psychiatrist with a special interest in serious mental illness. Ian Osborne, who's a pharmacist at the Maudsley, Kate Moffat, who's the lead dietitian at the Maudsley, and then Professor Donald O'Shea, who's a consultant endocrinologist and physician and clinical lead for obesity for Ireland's Health Service executive. And all chapters start with some text setting the scene, essentially defining the condition, describing the prevalence and impact of that condition, both in the general population, but also in the psychiatric population. And we learned that in the UK, approximately 60% of the public, of the general public, are either overweight or obese, and that number is 70% in the States. And we learned that obesity is associated with increased risk of various physical health complaints, including cardiometabolic disease, of course, but also musculoskeletal disease, cancer. The list goes on. And this translates into huge financial costs. In 2015, the NHS spent £6 billion on obesity-related ill health. The US spends $150 billion a year on these sort of complications. And the picture gets even worse for individuals with psychiatric disease. We learn that 80% of people with serious mental illness are either overweight or obese. And similar to what David was discussing before in terms of the reasons for that, we consider those reasons why, including illness-related factors, lifestyle, medication, etc. And as I said before, to make the text easier to digest and less prose heavy, where possible, we're using information boxes, diagrams, tables. So for example, in this chapter, we have a box here on calculating the body mass index, but then crucially its interpretation, what to do with those numbers. And then we have another box on with an accompanying diagram on the measurement of waist circumference, which sounds pretty simple, but actually it does get quite complicated because there are various different definitions out there, and we recommend using the World Health Organization definition. But then crucially, what to do with those numbers once you have them. And then moving on from that, we provide guidance on the monitoring of obesity in people with serious mental illness. And the information that we're giving, if we're not reinventing the wheel, essentially we are just distilling information that is already out there, that has been validated in the general population, but also validated in the psychiatric population. So we're using information from organizations such as NICE, the National Institute for Health and Care Excellence, the British Association for Psychopharmacology, and we're pulling that all together in a single sort of nicely accessible source. So for example, here we have, on the left, we have a table that sets out specific recommendations for monitoring of obesity and related metabolic dysregulation over time in individuals who are started on psychiatric medication, certainly antipsychotics, but also certain mood stabilizers such as valproate, lithium, that we know are associated with metabolic dysregulation, and also antidepressants such as tricyclics, mirtazapine, paroxetine, etc. We also advocate in the chapter of quantifying cardiovascular risk, i.e. the risk of heart attack or stroke over the next 10 years using the Q-risk-3 calculator. Now, this is a tool that incorporates a number of different cardiovascular risk factors, which you click into a web-based application, was a web page essentially. But as well as it incorporating classic cardiovascular risk factors such as age, your cholesterol levels, your blood pressure, the Q-risk-3 is unique in the sense that it's one of the first risk predictor algorithms that incorporates a diagnosis of serious mental illness and antipsychotic prescription into its algorithm. And this is just a screenshot of the Q-risk-3 calculator. And the idea, and I've done this myself in clinical practice, is to use this in your clinic and collaboratively working with an individual who you're seeing and going, well, look, you can actually tell them your risk of having a heart attack or stroke in 10 years based on the numbers that we have is X. And you can use that to engage with the patient on the topic of weight gain and of course, cardiovascular risk. So what do we do after we've determined that someone is overweight and potentially has associated metabolic dysregulation? Well, when I started working at the Maudsley about 6 years ago now, I mean, I noticed that there was certainly an emphasis on measuring physical health parameters in our patients. But then what I found rather frustrating was that there wasn't actually necessarily any clear plan for what to do if any abnormalities were identified, which in my mind rather defeated the object of measuring things in the first place. So really one of the key objectives for the book, I felt, was and what we try and achieve in this chapter, but throughout in all the chapters, is to provide guidance on how to intervene to improve the physical health of our patients. So it's all very well checking stuff, but then how do you act on those numbers? So what can we do? Well, of course, the first step for a number of disorders is simply to tackle lifestyle factors first. Now, in clinic, I have historically felt rather helpless when it comes to offering lifestyle advice to patients. And as doctors, it's drilled into you that lifestyle advice should be offered first before you pick up your prescribing pad. But I don't know if it was because of the medical school I went to, but I didn't get too much training on what that sort of lifestyle advice should be. So again, it was a real priority for us to try and provide through these chapters simple, practical advice that clinicians could provide patients in clinic, rather than just going, oh, you have to watch your weight, you watch your diet. Well, how can we watch it? And so Kate Moffat, who's the head of dietetics at the Maudsley, helped provide the information to this information box on the left here, which is just simple dietary advice for supporting weight loss. Now, of course, this isn't meant to be replacing the role of the dietitian, far from it. But, there are certain areas, certainly internationally, but even in the UK, where actually it's pretty difficult to get input from a dietitian. And even if you do have those services available, it can take ages for that referral to be made, weeks, even months. So it's these sort of simple, this simple advice can bridge that gap essentially. And I've actually started using this I've been printing out this box in my clinic, well, before COVID hit, and I've been emailing it in the new age of video consults. And excuse the pun, but it's gone down fairly well. I think on the right, it's also worth highlighting that there are a number of complementary standalone chapters in the book, which in terms of lifestyle advice. So for example, we have a whole chapter dedicated to physical activity, which was senior author was the head of physiotherapy at the Maudsley, Brendan Stubbs. We have chapters on alcohol and physical health, smoking cessation. So there are a number of chapters that can complement these lifestyle advice, the lifestyle advice that we want to be providing individuals. We then go on to consider the role of medication in driving weight gain in people with serious mental illness. And as I've already mentioned, weight gain is a major side effect of psychiatric treatments, and in particular, many antipsychotics. And, you know, what we've tried to do where possible is to use, you know, the most up-to-date evidence to support our advice, essentially. And so, for example, here we've used data from a recent large-scale meta-analysis that we actually performed, and it's really about encouraging the adoption of what we call metabolically minded prescribing. So essentially by preferentially using treatments with fewer metabolic side effects, as shown by this figure on the left, which shows the relative propensity of commonly used antipsychotics in essentially the risk of them causing weight gain. So where possible, using treatments with fewer side effects, and considering whether, if someone is already on a treatment that has metabolic side effects, whether we can switch that treatment to a treatment which has fewer side effects. Then we move on to think about, well, if we've tried lifestyle changes, we've tried to rationalize treatment. If that isn't enough, then what can we do next? And we go through the evidence for sort of essentially treatments that you can co-prescribe alongside psychiatric treatments to promote loss. And we consider treatments that specifically have an evidence base for use in the psychiatric population. For those of you who are interested in this topic, you'll be not surprised to hear that, you know, the treatment with the greatest evidence is metformin, and is, as such, is the first line recommendation for psychotropic induced weight gain. And then we also provide an overview of bariatric surgery, its indications and criteria that must be filled for patients to access surgery in the NHS in the UK, which of course will differ from country to country, and we acknowledge that. There is also, and we also consider the evidence for the efficacy of bariatric surgery in the psychiatric population. There is a reasonable evidence base of its efficacy in individuals with bipolar affective disorder, which we go through. And then finally, and we try to do this, you know, throughout the book, we provide an overarching management algorithm that summarizes all the advice that we provide in a single figure. And, you know, this is the sort of thing you think, oh, we could stick it up on the wall as an aid memoir to guide sort of day-to-day management. And then just on the right here, it's just a reminder of a number of the other complementary chapters in the book that will also be useful, that complement the obesity chapter. So for example, diabetes, which I'm going to be talking about in a second, but also all the other components of the metabolic syndrome, hypertension, hypercholesterolemia, etc. And of course, as we said before, smoking cessation, physical activity, alcohol, and then sleep disturbance, because as we know, poor sleep hygiene plays a role in the propensity to becoming overweight. And we have chapters on both sleep disturbance, but specifically obstructive sleep apnea. So let's quickly just take a look at the diabetes chapter. Again, as you'll see, this is the diabetes chapter in its entirety. Again, we've tried to be as succinct as possible, using tables, using diagrams, using information boxes where appropriate. In terms of the authorship, there is some overlap with the obesity chapter, but we have a senior author, Sophie Harris, who's the consultant endocrinologist and diabetologist at King's College Hospital, who took over for this one. Now, as with all the chapters in the book, you know, we kick off again with a definition of the complaint, in this case diabetes, before describing its prevalence and impact of that condition, both in the general population and in the psychiatric population. So it's very well characterized now that serious mental illness is associated with increased rates of type 2 diabetes compared with the general population. But there are certain groups where that prevalence is much higher. So we think it's twice as likely in serious mental illness as a whole. But in individuals, for example, with chronic schizophrenia, prevalence, if we're looking at sort of 60% of individuals seem to have a diagnosis of diabetes. And what this chapter also does in its introduction is it discusses the bidirectional relationship between diabetes and mental health. So we know that people with serious mental illness are at higher risk of developing diabetes, but we also know that people with diabetes are at increased risk of serious mental illness, in particular depression. And what we also know is that comorbid depression and serious mental illness translates into poorer management of diabetes. Okay, and so that's all in the introduction. the majority of the information in this chapter focuses on type 2 diabetes, but we do have an information box on type 1 diabetes as well, and the implications for the psychiatric population. It's a really complex area which requires a multidisciplinary approach. And also we consider the eating disorder associated with type 1 diabetes, so diabulimia, and the complications the difficulty that can arise in the management of individuals who present with that complication. The chapter then proceeds according to a structure that many of the chapters in the book follow, essentially describing the pertinent elements of the history and examinations that should be performed in order to thoroughly assess an individual with diabetes. So history-wise, although the majority of people with diabetes are often asymptomatic, one should still be screening for those characteristic signs and symptoms of hyperglycemia, so thirst, weeing lots, losing weight, blurred vision. And because diabetes can affect multiple organ systems, we should also be screening for evidence of end organ dysfunction, so blurred vision or visual disturbances that might point towards a diabetic retinopathy, or difficulty feeling pain, or temperature in the fingertips or the toes that might point towards a peripheral neuropathy. We also need to be thinking about other conditions that increase cardiovascular risk, and that is a key part of the history. So looking at screening for hypertension, hypercholesterolemia, etc. Looking at medication, looking at psychiatric medication that could be causative, but we also provide lists of common causes in physical health medication that might be worth looking at, but which might combine with the psychiatric medication to cause this perfect storm of a vulnerability to glucose dysregulation. And then a social history is important. So we need to get a flavour of how active the individual is, if they smoke, if they drink alcohol, because these are all potential areas for therapeutic intervention. And then we go through examination and we go through investigation. So again, examination should be normal except in advanced disease in diabetes, but we run through the examinations that you really should be doing and provide a list of investigations that will not only allow you to make a diagnosis of diabetes, but also to screen for diabetic related complications and broader cardiovascular risk. And then we go on to management. Now, it must be said that management of diabetes is multifaceted and can be complex and incredibly daunting for a psychiatric practitioner, especially if you haven't been looking after these patients regularly, and that's the spirit of use it or lose it in terms of your clinical knowledge. Now, in this chapter, we summarize in these boxes up top various international approaches to the management of diabetes. But of course, we're not advocating necessarily that psychiatric practitioners should start leading on diabetic management. That would be unrealistic and potentially even unsafe. But there are a number of things that a psychiatric practitioner can do, particularly as you may be the only medical professional that a patient sees regularly. So the first step, as we talked about in the obesity chapter, is considering non-pharmacological lifestyle advice, promoting weight loss, increasing physical activity, promoting smoking cessation, alcohol reduction. And increasingly, psychiatric services have facilities that are available to engender these changes. So they really should be offered. And of course, we have those individual chapters in the book that I've talked about that can also help in this vein. As with obesity, you also want to be thinking about rationalizing psychiatric medication. So identifying those psychiatric meds that we think might be causing a problem and having a collaborative discussion with the individual in clinic going, well, look, okay, so you've got some benefit from this treatment, but we've also, you're going down the line towards diabetes or you are diabetic. What would you like to do about it? Weighing up the risks and benefits of any psychiatric medication changes, which could improve your physical health, but I guess you've got to weigh it up against the chances of a deterioration in mental health. And anyway, and in this chapter, what we do is we provide, as we did in the obesity chapter, a list of medications that we think should be preferentially offered in the context of concerns about metabolic dysregulation, in the context of this chapter, glucose dysregulation. And the other thing a psychiatric practitioner can do is identifying when you think a patient might need to start pharmacological treatment for their diabetes, and then liaising or highlighting this with their GP or even secondary care if necessary, and working collaboratively. We also consider the notion of starting metformin early in people who are pre-diabetic, so they haven't yet met that threshold for diabetes, but who are going in that direction, who are overweight, and who, you know, and who are prescribed a psychiatric medication which you know is increasing the risk of diabetes, and you don't really want to be changing that medication either. And there is a reasonable evidence base, and it's something that we do suggest should be considered in some individuals. And then the final thing that you can do as a psychiatrist is making sure you're screening these individuals for other comorbidities that increase cardiovascular risk. Of course, this is already done. Well, the goal is to get this done in individuals who are prescribed antipsychotics. Making sure people with diabetes are linked up with their annual diabetic health checks. And also knowing when to, in someone with established diabetes, knowing when to reach out to colleagues in endocrinology or diabetology and going, look, I think this individual needs a review of their treatment. You know, if you've got an individual who's on a very complex insulin regimen, but they're a bit chaotic, a bit confused, then you know, this is a recipe for disaster. And if you pick that up, then you can make that referral. And what the book, well, the chapter tries to do, and again we try to do that throughout, is considering what information should you be putting in that referral to make the referral as good as possible, essentially, and, you know, really facilitate that transfer of care. And then finally, as with the obesity chapter, we then try and summarize everything in a simple management algorithm. It's important to highlight on the right that in our emergency sections, we've got 23 chapters dedicated to different emergencies, but we have a chapter dedicated to diabetic emergencies. This is probably more for individuals in an inpatient setting. And then, of course, a number of other complementary chapters that are available, chapters that focus on the complications of diabetes, chronic kidney disease, eye disease, sexual dysfunction, but of course all the other lifestyle related chapters, and the other chapters focusing on the broader metabolic syndrome. So those are the two chapters that I wanted to take a look at. And now I'm going to hand over to Fiona, who's going to be looking at a few other chapters which are less cardiometabolically orientated. Thank you.
So welcome. I'm just going to share my screen. Thank you very much for joining us this evening. I'm Fiona Gochran. I'm consultant in the National Psychosis Unit in South London Maudsley Trust, and I'm a reader in physical health and psychopharmacology in the Institute of Psychiatry, Psychology and Neuroscience. I'm very excited about this book being out because ever since I left medicine and went general medicine, went into psychiatry, I've had a long-term interest in people in mental health services getting informed access to medical care. And the book just brings together the work of 125 colleagues who have been fantastic. It's been a joy to edit, and on all these topic areas. And I feel so much wiser having read it, and I hope that it's going to be really useful in clinical practice. What we're going to do is illustrate the point to see how explain how the book covers the physical side effects of the antipsychotic drug Clozapine. Now, people use Clozapine because their psychotic illness hasn't responded to anything else. But it has a number of side effects. Now, David went through with you earlier about how antipsychotics have both a positive and a effect on life expectancy, but also introduce challenges because of the side effects. Clozapine, and it's presumably because of the direct toxicity of psychosis itself. Clozapine is necessary for some people whose psychotic illness doesn't respond to at least 2 other non-Clozapine antipsychotics, but it undoubtedly has the heaviest antipsychotic burden, side effect burden of all the antipsychotics, really, covering this array of problems across the various different systems. So that's way too much to discuss in one session, particularly a relatively short one, but we're going to just pick a few examples of how what side effects that people can get. We're on the 4th slide, Kieran, for this, because I'm not sure you're seeing my screen. And so some in the gastrointestinal system, some in hematology, and then to go into the emergency section, we'll talk a little bit about sepsis. So just to remind you, the Maudsley Guidelines for physical health give you a definition of the complaint, talk about common causes of the complaint in the general population, and then makes that more specific for how this might be, things you need to think about in people with severe mental illness. How you examine, take a history, what investigations to do, when to refer, who to refer to, what to say about it, and some points about how to manage both in terms of pharmacology and non-pharmacological approaches. The first thing, and arguably one of the most important things for people on clozapine, is constipation. And this chapter, as you can see, is written by John Lally, who's based between the UCD and the Royal College of Surgeons in Ireland, with input from Toby and from Calliope Valianatu in our pharmacy, and Imo Weikart in Ipswich. So it talks about constipation in general and psychosis. And of course, people with schizophrenia, for example, have a sedentary lifestyle, maybe have obesity, have a low intake of fiber and don't take that much physical exercise, and may be at risk of becoming dehydrated, all of which increase your chances of developing constipation. But on top of that, clozapine has a direct effect on the motility of the gut. It has anticholinergic activity, which can lead to a hypomotile gut in its own right, plus some antihistaminergic activity. And on top of that, its major metabolite, norclozapine, has some effect on the opioid receptors. And because of all of that, the pooled prevalence of clozapine-associated constipation is about a third of people experience that. And it's 3 times as likely on clozapine as on other antipsychotics. And it's not related to the dose, and it's not related to the level. And of course, constipation in its own right can cause complications. It can be unpleasant for the person at its lower level, but if unidentified and not treated, you can end up with impaction, obstruction, ischemia, necrosis, perforation, or sepsis. So it's really important that we screen. And you'll see at the beginning of the front page of the chapter there, the Bristol stool chart, which is, we use a lot of clozapine in our service, and we have up in the back of the walls of the toilets, so that people can report to the nursing staff, who will routinely ask them about their bowel habits in detail when we're starting clozapine. So if we move on to the next slide, this exemplifies the algorithms that are sort of throughout the book, really. And if somebody presents with clozapine-related constipation, you want to know, is this an emergency? Have we got any evidence of sepsis and acute abdomen, in which case you go down the emergency line straight to the back of the book, and if necessary, emergency transfer to our our surgical colleagues. But if it's not an emergency, you're starting from scratch and recommending sensible approaches, such as optimizing water intake, so long as it isn't already high, increasing fiber intake and physical activity, and rationalizing the medication. So stopping any other anticholinergic drugs. In fact, there's a great website developed by our Biomedical Research Centre called Medichec, MEDICHEC, and which allows you to consider the anticholinergic load of the various medications people are prescribing. So reduce other anticholinergic drugs if possible, and really use the minimum effective dose of clozapine, which of course we should be doing all along, but it's important to consider, is this the minimum effective dose? But alongside the non-pharmacological advice, we need to think about laxatives, and in fact in some centres people are routinely starting laxatives when they start clozapine, and going quite early onto stimulant laxatives such as Senna, which directly affect motility because of the basic underlying problem. Here you might also consider docusate sodium, which is an emollient laxative. And if that doesn't work, after 48 hours, you might increase the dose gradually. But if that still doesn't work, that you would want to do a rectal examination to look for any impaction, consider the possibility of glycerin suppositories or phosphate enemas, and at any stage during that pathway, if diarrhea develops, gradually reverse the steps until the sort of interval of bowel movements is optimal. However, if it doesn't work, it's important to discuss actively with medical and surgical colleagues who can advise on whether we need to increase the dose of macrogol, which is an osmotic laxative, or consider the use of a secretagogue, such as linaclotide, which is a guanylate cyclase C receptor agonist. that accelerates colonic transport, or prucalopride, which affects the serotonergic system. The next thing that's important for people, anybody on clozapine, is hypersalivation. And this chapter, again, Toby had a hand in it, but also with colleagues from Italy and King's, Enrico D'Ambrosio, Andrea Falsetti, and Professor Stephen Chalacombe, who's emeritus professor in the King's Dental Institute. And the difficulty with hypersalivation with clozapine is that excessive salivation can happen either during the daytime or at night, or all the time. It's due to agonism of the muscarinic acetylcholine receptors and blockade of the alpha-2 adrenergic receptors, as well as sometimes sedation causing reduced clearance of saliva. The definition of hypersalivation is given in the chapter. It's an unstimulated whole saliva flow rate of more than 0.8 mils per minute, measured with cyanometry. And again, here we have an algorithm of how to manage it. And starting again with the sensible thing, are you on the lowest effective dose of clozapine? And looking at lifestyle advice. Can you sleep with at least 2 pillows? Sometimes chewing gum can help during the daytime. A towel of the pillow can help if salivation is particularly problematic at nighttime. And things like a dental referral, if somebody is has problems with their teeth or indeed their gums, because that can provoke the hypersalivation. The next thing you need to ask, if that hasn't helped things, is the person experiencing other anticholinergic side effects, such as constipation, or do they have any contraindications to anticholinergic medications, such as narrowing glaucoma? If the answer is no, then a reasonable place to start is hyoscine hydrobromide. And my colleague James McCabe ran a RCT in our service there recently and found that yes, there is evidence that this works. Up to 3 times, 300 micrograms up to 3 times a day, sucking the tablet, but monitoring for any emergence of constipation in particular, or any other anticholinergic side effects. And if it doesn't work, stop it and change over to oral metoclopramide, which is a dopamine receptor antagonist, which again can be given 3 times a day. But if that doesn't work, again, stop it. And if somebody continues to have psychotic symptoms despite the clozapine being optimized, then a small dose of amisulpride may help. Bearing in mind that higher doses of amisulpride, you might get quite high levels on them, so they would need ECGs, etc. But if that's not a likely option for somebody, then actually local use of 1% atropine eye drops, up to about 3 drops, swilling in your mouth with water and then spitting it out. So getting the local effect can sometimes help. But if all of that doesn't work, then we're talking again to linking with our dental and radiology colleagues for the consideration of parotid salivary gland botulinum toxin, Botox injections. The next chapter I'm going to mention is neutropenia, and all the psychiatrists in the audience will be well aware that when we are prescribing clozapine, we have to check for neutropenia weekly for the first 18 weeks, fortnightly for the rest of the first year, and monthly thereafter. And it's very strictly monitored, and if someone's neutrophil count goes below 1.5, that's called a red light and the prescribing stops. That cutoff is in fact lower in the USA. It's 1 in the USA, and because they've taken in some more recent evidence in their regulations. And of course, the thing we're trying to prevent is agranulocytosis, which is defined as the neutrophil count going below 0.5, which is much lower. And the rate of agranulocytosis is about 0.8% over the first year in one older study, with a peak incidence of between 6 and 18 weeks. But with more regular monitoring, the incidence of agranulocytosis on clozapine had reduced. But it's important to avoid it. The mortality due to clozapine-induced agranulocytosis is diminished since the initial reports, but estimates range from about 2.7 to 3%. So it's important to try to prevent that. So that's what the monitoring is about. But sometimes what happens is that somebody has had a red light. And the question that comes to you is, can you give them clozapine again? Because the reason they might have gone on clozapine in the first place is because nothing else worked. And so therefore it's a very valid question. If you've tried other things and you can't go back and they don't work, how safe is it to try clozapine again? So then you're looking at the differential about why somebody might, or other reasons somebody might have had for getting a low white count. Some of the more common ones in practice might be a congenital reason, such as benign familial neutropenia or benign ethnic neutropenia. And this chapter on neutropenia was written by our, again, John Lally, who worked with us in Dublin before he went, in London before he went back to Dublin, and Toby, and also Alex Miovic, who's been a really great hematological colleague at Cross and King's. So he's helped us in many ways, trying to identify people with benign ethnic neutropenia, which is a hematological diagnosis of exclusion linked to the Duffy blood group gene. And but it's a potential inequity because it's more common in people of African heritage, but that group can then be thought, if they have it, they can be thought not eligible for clozapine and therefore not get the best treatment for them. So it's important to diagnose it where that's relevant, so that people have equitable access for the best treatment for their mental illness and therefore reduce the toxic effect of untreated psychosis and getting that balance as good as possible for them. Nutritional factors are also important. Copper, B12, folate. Also various infections can cause a reduction in white cell count. Certain autoimmune diseases such as SLE. And of course other drugs. And in our world in psychiatry, the most common offender is sodium valproate, which our meta-analysis showed increases the chance of neutropenia, a red light on clozapine by 2.2 times, an odds ratio of 2.2. So then again, do you, with all that information, do you give the clozapine once more? Well, the literature is difficult to interpret, as in the literature, it's difficult to be absolutely certain about the cause of neutropenia. Is it directly due to the clozapine or not? But clues that it might be would be a low level of neutrophil count and agranulocytosis, it happening early, before 18 weeks, although we have seen them later. It lasting for a while, more than about 10 days or so, and it's happened again after you've been rechallenged. So those would all suggest it might be clozapine induced. Drugs like lithium and granulocyte colony stimulating factor can make your bone marrow produce white cells, and they'll stop the neutrophils stopping for other causes, but they won't stop a recurrence of a clozapine induced neutropenia. If somebody's main problem is that they have benign ethnic or familial neutropenia, then we can discuss the possibility of altered adapted cutoff thresholds for the red lights. But overall, we suggest that rechallenge after an agranulocytosis, if it's gone below 0.5 by 10 to the 9 cells per litre, that's more risky and we wouldn't advise it. And the reason we wouldn't advise it is because we don't want somebody to be susceptible to having a bad outcome if they happen to get sepsis. And of course, one doesn't have to be to have neutropenia to get sepsis, but anybody can get sepsis, but it is to be avoided if possible. And it's, this final chapter I'm going to speak about here was written by our acute medicine colleagues, Laura O'Sullivan from GSTT and Imo Weikart up in Ipswich. And thank you very much to them and to all the other 125 authors in awe. They were fabulous. So it's such an important area. It's defined as a clinical syndrome. These days it's defined as a clinical syndrome secondary to a dysregulated response to infection, which is usually bacterial infection, which then results in multiple organ dysfunction. And as you'll see here from the chapter, there are ways of defining it. The most common one we use in practice is the National Early Warning Score. And if that's up I'll move to the next slide actually, if that's up over 5, or a single factor within the new score is up over 3, then we have to think, could this be sepsis? Or somebody's just acutely unwell and you're clinically concerned about it. If you think it is an infection, well, yes, then you still need to keep that in the back of your mind and review the person until you're clear what is going on. But if you do think it's infection, we really need to be treating this person, investigating them very quickly. How much of this investigation and management algorithm you're able to complete, that will depend on what resources and expertise you have locally. But the bottom line is to call an ambulance, because what you really need is to have your sepsis 6, which is at the bottom of this algorithm, completed within an hour. Now, on that point, I'm going to hand you back to David, and thank you very much. And again, thanks to all the authors.
Thank you, Fiona. Now, thankfully, we've got lots of questions in. I've typed a couple of answers just in case we get squeezed for time, but I'm happy to discuss them further if we do have time for them. But I'm going to pass over to Toby now, who's been looking at the questions, and he's going to either answer them himself or pass them on to me or to Fiona to comment. Toby.
Thanks, David. Okay, apologies in advance if we don't manage to get through everyone's, but we will do our best. We've got a combined question here from a couple of people regarding metformin, prescription of metformin in people with serious mental illness and for weight loss. And 2 individuals have said that it can be difficult to convince GPs to continue metformin prescription that's been prescribed by a psychiatrist, and whether we had any advice on how to work better maybe with our colleagues in primary care or more collaboratively. I mean, I think from my perspective, this is a broader problem than just metformin. We know that there are certain medications, psychiatric medications that are novel or relatively novel, that have fewer metabolic side effects, that we are trying to prescribe preferentially at the Maudsley or in psychiatry. But because they're so new, they're quite pricey, and that means it can be difficult for primary care to want to take over that prescribing responsibility. How we can fix it is a difficult one, and I would hope that, you know, through initiatives like this book, that we would start to try and, you know, start the dialogue between secondary psychiatric services and primary care in trying to facilitate more collaborative ways of working. And I think I think it's unfair to broad brushstrokes say that all GPs won't do this. I think you'd be surprised. There are certain GPs who are able to. Fiona, you were putting your hand up there.
So I think your point about people needing to think a bit about the expense of the newer, less metabolically challenging antipsychotics is very important. But the other thing that can be useful is the Leicester resource. So that's been licensed for not just use by psychiatrists and GPs, but also for patients and carers. So I don't know, we might be able to put up a link to the Leicester resource in the chat before we finish. But I think David Shires hopefully was a co-author of it and was planning to join today. And an incredibly useful red, amber, green resource, you know, talking about the sort of standard things: obesity, sugar control, lipids, exercise, etc. And it's something that you can take, and it mentions metformin on it. And I think my recollection is that David expended quite a bit of energy to make sure it mentioned metformin, so that it is, and explicitly says it's possible to use that if somebody's at risk of diabetes, because I think some of the GPs initially had concerns about it being off-license use. So that my advice to people would be to print out the Leicester resource, circle where they are on it, and get them to take it in their hand to the GP, and as a way of initiating conversation and having that ratified at a wider level, because it's included in those guidelines.
And you won't be surprised to hear me say, but you could also show them this book.
Toby, can I add that metformin has a somewhat mixed reputation. Obviously, there's the risk of lactic acidosis, which I suspect is probably overstated. There's also the interaction with alcohol, which may or may not apply to our patient cohort or individual patients. And also the risk in people with low GFRs, But if you put those things to one side, it's a pretty innocuous drug with few adverse effects, save nausea when you first start taking it. Obviously, when prescribing is passed over to GPs, they take responsibility for that prescribing, and I understand why there are worries about it being off license. But we can, as you rightly point out, legitimize the prescribing by having it written in such learned publications as the one we're talking about now. And that actually happens with the other Maudsley guidelines. That's seen as legitimizing off-license use in some way.
Okay, we've got another, I'll read out this question. A worry I have is that even armed with this resource, psychiatrists will still feel reluctant or nervous following the guidance for their patients, preferring to hand things over to GPs or refer to secondary care. What are your thoughts on how to drive behaviour change? Fiona, did you have a...
How to drive behaviour change? I mean, we completed a very large trial trying to drive behaviour change with 400 people across 5 trusts, training up people's care coordinators to use motivational interviewing and cognitive CBT techniques to try and influence people's lifestyle choices, and didn't find an effect. There have been 3 other studies in Europe has had a similar sort of absence of effect. It's very difficult at a general level to drive lifestyle change. Where they do get some results is with when you bring in specialists and spend quite a bit of time. So it's an intensive affair. You need to have dietary specialists, exercise specialists, and it's not cheap. Yeah, absolutely. And starting early is very useful. So the Keeping the Body and Mind group in Bondi have done a remarkable job where this is, physical health is focused from the minute somebody walks in the door, and their follow-up studies over 2, maybe more years have shown that people's weight and waist circumference remains reasonably stable when that becomes a focus, and exercise and dietary advice are integrated into the package of care that people are given. So you can do it from the start, but if you're trying to reverse things, then quite an intensive approach is needed, and that's a challenge across services as to who funds it.
So difficult to engender behavioural change in the patient, but I think what we're also thinking about is behavioural change at the level of the psychiatrist, in terms of taking responsibility for physical health management. And you do see that on the wards. You see a reluctance, or I've seen it, a reluctance to engage with troubling blood test results with the expectation that, well, follow up by the GP. And the problem, and that may be very okay in a general medical hospital, but I suppose as we're all aware, the problem in the psychiatric patient population is that for some of our patients, it's much less likely for those individuals to then actually engage with primary care. And I think, it is about engendering a change in philosophy in psychiatry. And this is my personal viewpoint. I mean, I could put it another way, shall I? If I were a rheumatologist or a respiratory physician in a different life, and I gave my patient lots of steroids, oral steroids for many years, and they ended up with diabetes as a result, would I be managing their diabetes? No. I would be expecting the GP and endocrinology to manage it. So I suppose a legitimate question is why should it be any different for psychiatrists? And I think it comes down to the fact that we have a very different patient group who can be difficult to engage with. So I think we do need to engender change, and it's through things like this book, but it's also through education from early on about giving people the confidence to be able to do stuff and to work to the limit of your own ability, but feeling confident to be able to ask for help if you need it. And that's, again, what this book is trying to do. Any other comments from Fiona and David? Okay, we'll move on. Oh, sorry, Fiona.
Yeah, you know, and it's about working in partnership as well. Sometimes it's about picking up the phone and deciding who's going to do what, and and try to make it happen. The key is, so on the inpatient side, you know, the psychiatrist is there providing frontline care and needs to do it. On the outpatient side, the psychiatrist's responsibility is to make sure it happens somehow, ideally in standard services, but then figuring out, looking creatively at how to make it happen.
Absolutely. Okay, another quick one, a bit sort of more specific one, this one. So national risk calculators have not included antipsychotics on their risk tools for DVT and PE assessments for inpatient units, despite data that suggests the risk may be in excess to that associated with oral contraceptives, for example. And it's asked, have we included a reference to this in the book? Well, it's an interesting one, because I think from my perspective, I learned a lot through putting this book together, and I was astounded that there weren't any. So when you go into a general medical ward, you can't, you know, you've only been on there for 5 seconds, and your risk for a clot on the lung or in the leg has been assessed, and you've either been written up for some heparin or you. But those risk assessment tools, they only exist in general medical hospitals. And of course, in psychiatric settings, you know, there are patient groups that are at increased risk of DVT and PE, people who are not moving, stuporous, catatonic, old age psychiatry, etc. And we recognize that in the guidelines, in the chapter that we have on VTE and PE, and we recognize that there actually isn't a validated tool for use in the psychiatric population, and we need one. But in the meantime, we should be using the tools that we have that have been validated in a general medical hospital, essentially. Any comments from David and Fiona?
No, that's right. Yeah.
Think of some more general ones, shall we? Okay, so many hypertension guidelines suggest that we should be more aggressive with managing hypertension in people with diabetes. So you use lower thresholds. You aim for a lower blood pressure in people with diabetes compared with people who don't have diabetes. The rationale being that diabetes increases your chances of cardiovascular disease so much that you want to be as aggressive as possible with management of, you know, of other cardiovascular disease risk factors. With that in mind, Fiona and David, do you feel that we should be employing similar tactics in people with serious mental illness, or in particular sort of psychosis, where we know individuals are at such higher risk of cardiovascular disease? Should we be using lower thresholds for treating hypertension?
In particular, I mean, I think that we need to be really aware of everything, really. And, you know, you gave a very nice summary of cardiovascular disease. But I think it's across the board. We just need to have high levels of awareness. I'm not suggesting that we should have any changed cutoffs. I think the Q risk discussion, Dolly, you've put down some mentioning of Q risk, and I think there are issues with the age cutoffs there that you know that make those scales less applicable. But of course, some of the antipsychotics can make reduce people's blood pressures as well, so that the you know, having a blanket adjustment may be challenging. But I think that awareness needs to be from a very early start. So if we could bring that, you know, so those sort of algorithms of when you need to start thinking about giving people advice for prevention, etc., I think they need to kick in from the very early start. I think the pharmacological interventions would be much more individual based. I don't know what David would think.
I think if we could move towards a situation where we did at least as well with people with serious mental illness as is done with the general population, then that would be a great step forward. We're kind of getting ahead of ourselves, asking for lower thresholds and more aggressive treatments. If we could match the aggression of treatment in the general population, that would be a major step forward, I think.
Yeah. Okay. Here's another one that I was thinking about. So in the 1970s, we had the introduction of liaison psychiatry in Oxford, this innovative and pioneering service which brought psychiatrists into A&E, and it's since blossomed and is now sort of endorsed throughout the country and in the UK. Bearing in mind everything that we've talked about today and the burden of physical health conditions in patients with serious mental illness, is it time for a liaison physician service to be set up where you have physicians coming across to the psychiatric hospitals?
Well, I very strongly believe that that is the case, and have done for a long time. And of course, the challenge, of course, is introducing that without further de-skilling our psychiatry team. So some systems where they have patients who are inpatients for a long time, particularly I'm thinking of forensic settings, often have a GP coming in, and the patient may be booked in to see the GP. And you know, and that can work very well because that's the model of care needed, provided, as I say, you don't abdicate all responsibility for physical health to the GP. In our, you'll be aware that you've been working with the Mind Body team, our improving mental health, improving physical health service and mental health settings team run by the King's Health Partners, and that's it's just started up a virtual, it's now virtual, physical health clinic, and once a week on our new access to online consultations, and that's we're evaluating the effect of that at the moment, and are very pleased to have it, but need to get the evidence of its effect. But I strongly believe that this is something that we've needed for a long time. To have that in reach, not just to treat the patients, but also to educate our staff, stop staff becoming de-skilled, becoming out of practice, educating a learning and supportive and developmental way.
We tried it with specialist pharmacists. Again, this is because King's is so close to us. So the specialist pharmacists can walk across from King's to Maudsley, and we engaged a team of them about a year ago, and we were slightly worried that they wouldn't have enough to do. As it turned out, they had more than enough to do. The plan has rather gone awry since the arrival of the pandemic, but it did show us that there was a great deal that we could learn from these individual specialists. And I agree that there is a worry about de-skilling, but my observation was that it actually made us more skillful in that, you know, we were made aware of things that otherwise would have passed us by.
Yeah. And learning from colleagues.
Yeah.
Yeah. So that we're all able to provide better care.
Yeah.
Okay, another reflective one. David, you talked about Graham Thornycroft and the public health scandal of the excess mortality in people with serious mental illness compared with the general population. Why do we think that mortality gap isn't narrowing over time, or even it might, according to some data, be getting bigger?
Well, for one, it's difficult to measure. There are all kinds of confounders in the information that we get from what happens to be very few countries that have countrywide medical records, mainly Scandinavia and Finland. So we have data only from them, really. And as I say, it is confounded. But you're right that it shows either no change in the mortality gap or a slight worsening. And it isn't altogether clear why that is. That the main causes of death remain the same, which are cardiovascular, suicide, cancer, in that order. And maybe it's got something to do with those aspects. And of course, it may well be that the advent of atypicals with their rather kinder profiles, but rather less kind metabolic profiles, has at least not allowed the mortality gap to shrink.
Yeah, and and I suspect the fact that we haven't had huge leaps in the effectiveness of our antipsychotic portfolio either helps, because what we're doing is we're trying to moderate the side effects, the adverse effects of the drugs we're giving. As we've mentioned earlier, there's sometimes our cost restrictions on people getting access to those less metabolic heavy drugs. But we haven't, clozapine's been out for a long time. Beyond clozapine, we haven't got major improvements, and therefore the sort of direct effect, and all the sort of societal, the wider determinants of health, urban living, low incomes, etc. All that is still there, and we haven't made major inroads into treating psychosis better. So we aren't actually reducing that gap of the toxicity of psychosis itself. So we're doing, as there is the sort of varying different effects of the antipsychotics at play, but there's a lot of other things that haven't changed too. So it all needs to be addressed as a package, and it requires very big level thinking, which I think the Lancet Commission tried to bring together at a wider level. And there's opportunities to take it forward, but it remains a challenge. And of course, life expectancy in general, until relatively recently, has been rising in the general population, and has risen a bit in our population, but not as much. That gap is still there.
Thanks, Fiona. Fiona, you very nicely summarised all the side effects that clozapine can have as a treatment, and yet we know that it's such an effective medication for some people who take it with treatment-resistant schizophrenia. Is it possible to have effects without side effects in psychiatric treatment?
I don't think it's possible to have effects without side effects with anything. And in some ways, if you take the thing that anything is a drug, and everything has side effects, even if you take enough water. But it is all about value, isn't it? It's all about acknowledging that getting maximal benefit from something. If something doesn't benefit you, then that side is diminished, and getting the fewest possible side effects that you can on the other side, bearing in mind that even if you don't have any physical side effects, and some medicines don't have troubling or difficult side effects, but for some people the mere act of having to take a pill every day, or having to take a treatment, or having to turn up to psychological, whatever it is, the mere act of engaging in treatment is in itself a cost versus the gain. And so it's important that we work with everybody and listen to make that, the value of every intervention maximal for people.
And I suppose slightly related to that, but is a comment here in the questions whether we should be seeking informed consent to continue medication from patients who develop diabetes when they're taking drugs like olanzapine or clozapine. Similar risk profiles, don't they?
I mean, totally. I mean, we need to engage people in their treatment choices all the way. And so, if you're taking olanzapine and you think your diabetes is directly as a result of the olanzapine, then it depends on how good, then you want to have that conversation. What's the good sides? What benefit am I getting from this? What's the cost of doing that? Is there something that could give me more benefit? Is olanzapine doing the best possible job it can for me? And what would be the downside of changing? And and sometimes there are downsides to changing. And again, it's not neutral. It's not, if I take away the medicine, there won't be any problem. If I take away the medicine, actually, then there is a risk that how do we manage the mental health issue to again maximize that value, the gain of the intervention versus the cost of the intervention. Absolutely. So as trying to, and the idea of all treatments that we're doing it very often is trying to get somebody to the point where they have capacity to engage fully in those conversations, because they're important conversations. These are lifelong medicines often.
And David, should we be worried? If we take schizophrenia as an example, and people get worried about the notion of changing treatments that might be, if we want to check, we think olanzapine's caused the weight gain and the diabetes, so we're going to change to something which is a bit metabolically more neutral, should we be worried that that might have an impact on mental state?
We should be worried, but actually there are two good studies. One of them showing that there's a slightly increased risk of treatment failure when switching from drugs like Clozapine and Lancet, risperidone to aripiprazole. Also in that study, they showed that there was a rather greater risk of abandoning treatment. So patients not liking it, but you'd kind of expect that if patients were settled on one treatment and we randomly gave them something else. The other study, which is the more recent one, looked at switching from those three drugs to aripiprazole and looked at outcomes such as relapse, rehospitalization, that kind of thing. And actually what they found was a tendency, a trend for patients to do better. There were no statistically significant differences. Having said that, we will all have experienced or had the experience of patients, for one reason or another, being compelled to give up a drug that was working for them and try a different one, and for the efficacy that was evident with the previous drug to disappear in a puff of smoke. And occasionally we have this forced upon us when manufacturers run out of drugs. About 10 years ago, maybe it's 15, trifluperazine was in very short supply. And I recall many people who'd been settled on that very old drug, sometimes for decades, were switched to something like risperidone, and a good proportion of them relapsed. It may be because it's a different drug, it may be because we give them effectively a different dose, but it always carries with it at least a small risk, I think.
Okay, thanks, David. I think we're coming to the end of the show, I'm afraid. So, David, I'll hand over to you. Apologies to those whose answers we weren't able to, whose questions we weren't able to answer.
Okay, thank you very much, Toby. It remains for me to say goodbye and to thank various people. I particularly want to thank, and I know Toby and Fiona do too, all of the contributors to this new book. We needed clearly their expertise in order to bring this book about, and we are extremely grateful to each of the contributors to this book. Thanks also to Toby and Fiona for putting up with me while we put this book together. Thanks for Maudsley Learning for putting together this webcast. It's been a joy to work with you. Thank you to Wiley, the publishers, who have agreed to publish this book on our promise, Toby's promise that it's going to be a big seller, and we hope it is. But lastly, thank you to you, the audience, for staying with us. We've had nearly 200 people listening tonight. Thank you for the questions that you've asked that have enlivened the evening. So thank you and good night, everybody.
Thanks very much.